Daniel is an active 8-year-old enjoying a typical afternoon in the park, but today something unexpected is about to happen.
My heart feels weird.
Daniel, what's wrong, sweetheart?
I don't know what's going on.
Someone call 911. His heart's racing.
911, what's your emergency?
My son's heart is racing. He's dizzy and pale. Please send help.
Help is on the way. Keep him calm, try to have him sit upright, and don't let him lie flat down.
What's his name?
Daniel, he was running around and then his heart started racing.
What's up, buddy? What's going on today?
Scared.
Dollar blood pressure and pulse ox.
Alright,
You're scared?
What's
What's going on?
I can't stop breathing.
When this
So
happened?
fast.
Oh, control your breathing, okay? My partner right here is gonna get some vitals from you. Bring that in front of him. Oh. Here you go. Checking his pulse. He's cool pale. Cool and pale? Thank you.
Pulse is fast and regular.
Okay. What were you doing?
His pulse rate is about
Turn around
220.
ball.
Your ball? Okay. Seems like SVT. Get him on the leads, Dollar.
I got you. And his blood pressure is 99/64.
Cool.
I got the leads on for you.
All right, thank you. Confirm SVT. All right. You want to try to blow this on the syringe? Here you go. Blow as hard as you can, like a balloon, okay? No conversions. Dollar, can you start an IV for me?
I'm already on it.
All right, thank you. All right, he's stable. We're gonna move to adenosine now, okay? So his mom said he weighs 25 kilograms, so we're gonna drop 2.5 milligrams, okay?
All right.
All right, when you're ready, I'll take that.
It's ready. Let's go.
All right, this is a medication that's gonna help reset your heart, okay?
Wow. That feels weird.
Feels weird?
I hit capture for you.
All right. All right, no conversion. All right, dog, I'm gonna do a second dose of adenosine. Get the pads on just in case this doesn't work, okay?
Copy.
Okay.
All right, these are gonna go on your chest, okay, buddy?
All right, gonna push the second dose now.
I'm gonna hit capture for you.
All right, and all right,
Feels so good.
that's normal, okay? Okay, is that it? All right, looks like we're gonna have to shock him.
Oh no, Daniel.
All right,
You're all right, Daniel. Wake up, Daniel.
25 joules, we'll go to 30.
Oh,
All right,
Daniel,
we're gonna
asshole.
press sync first. All right, charging.
Wake up, Daniel.
All right, Dollar, clear.
What?
Get off of him.
Oh, I'm sorry.
Shock delivered.
Is he okay?
Wow. You guys saved me. Thanks.
All right, how you feeling now?
Can I go back to playing?
Sorry, we're gonna have to go to the hospital.
Darn it.
SVT in children can be sudden and frightening. Recognizing it early and initiating treatment quickly is critical. Now that you've seen the scenario run regarding pediatric supraventricular tachycardia, we're going to go more along the lines of the pathophysiology and also AHA protocol, including what is to be done first and just everything following the American Heart Association. So if you don't already know, supraventricular tachycardia is categorized as a subset of rhythms that is a tachycardic rhythm that the cause of the tachycardia is above the ventricles, supraventricular. In this photo I have placed, this is an example of AVNRT, or atrioventricular nodal tachycardia. The reason behind AVNRT is the SA node, or the sinoatrial node, which is the pacemaker of the heart, fires off the electrical impulse to the atrioventricular node, which then gets caught into a loop, a reentrant loop, and keeps firing. And both of those nodes are above the ventricles. Therefore, this would be categorized as a supraventricular rhythm, but the categorized name is atrioventricular nodal reentrant tachycardia. This next photo I have placed describes the pediatric tachycardia with a pulse algorithm from the American Health Association. So just like in school, the first thing you're going to want to do when you identify that you have a patient with a tachycardic rhythm is, before you administer any medications or an attempt to slow their breathing down, is you want to make sure that their airway is patent, because with pediatrics, a lot of the big times they go into cardiac arrest, neonates, infants, pediatrics, is due to respiratory. Their respiratory system is heavily dependent on the heart, and if anything compromises the respiratory system, it inevitably will affect the heart as well. So as long as you have a clear and patent airway that requires no immediate intervention, such as an endotracheal tube or an airway adjunct or a supraglottic airway, you can then move on to your 12-lead EKG and also your other vitals. The only way you're going to be able to identify that a patient is in a supraventricular rhythm and not a sinus tachycardic rhythm is by first off looking at your 12-lead EKG and determining if you're able to identify P waves. If you aren't, and it's a narrow QRS, you are most likely in a supraventricular rhythm. So once you have found that you are in a supraventricular rhythm, you need to make sure that the patient and make a diagnosis if they're stable or unstable. If they're stable, meaning they have good perfusion, they aren't altered, they don't look like they're going to die within the next couple of minutes, you have a couple of options. The first main go-around, which is shown in the video, is going to be your Valsalva maneuver. One of the easiest ones you can do is grab a 10 cc syringe and push the stopper all the way to the end and try and have the patient blow onto it. If you have a super young pediatric patient that doesn't speak or understand communications to that extent, you can always do a modified Valsalva, which is you take the patient's feet and put them in the air while the patient is laying on their back, and then you quickly move them upright and into a position change. And the benefit of these, or the main purpose of these maneuvers, is to stimulate the vagus nerve. If that vagus nerve is stimulated enough, it could cause a rapid drop in their heart rate, enough to get them out of that dangerously high tachycardic rhythm. Secondary to Valsalva maneuvers, because those are not always effective, you would move to the medication route so long as they are still stable. The medication you'd want to use for a narrow complex tachycardic rhythm is going to be first-line defense, which is adenosine. Adenosine essentially stops the SA node from firing for a brief amount of time. The half-life of adenosine is 6 seconds long. So for about 6 seconds, you will not have any AV nodal activity in the heart. This drug is very finicky in order to work. You have to have a rapid IV push followed by a saline flush, because if the medication doesn't reach the heart in time, it would have already expired the half-life and would not be effective. So timing is very key with this medication, and this can be done in 2 doses. Dosage differ between different agencies and whatnot, but the American Heart Association says to do 0.2 milligrams per kilogram with a max of 6 for the first dose, and then 0.4 with a max of 12 on the second dose. So again, these don't always work, but if they do, they typically bring your patient out of a supraventricular tachycardic rhythm. And if those maneuvers and medication don't work, your last line of defense pre-hospital is going to be electricity. For electricity, you're going to want to shock at around 2 joules synchronized, 2 joules per kilogram synchronized, and that should hopefully bring them out of the rhythm. When I say synchronized, you're essentially tracking with your monitor every time a ventricle depolarizes. So with the monitor, you are able to see an S over the QRS complex, meaning that the computer inside the monitor has a understanding of when the ventricles are depolarizing and will only deliver electricity when it sees a QRS complex or ventricular depolarization. This is kind of a last line of defense because it's very painful and it's not something you really want to mess around with. But if your patient is really starting to deteriorate, it's unfortunately something that you're going to have to do in the field.